This is universal and not just because you have an athlete on the team with a known condition, right? So we have to have proper emergency preparedness for cardiac arrest at all of our sporting facilities and sporting events. This is a top priority for sports medicine and athletic training.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. I have the fortune of having with me a special guest from University of Washington in Seattle, Dr. Jonathan Drezner. Dr. Drezner is professor of family medicine at University of Washington in Seattle. He is the director of sports cardiology. And we are going to be discussing a topic which has become of great interest, to sports medicine physicians, to family physicians, as well as cardiologists, and that is the heart of the game. Assessing cardiovascular risk in athletes. So, with that introduction, and without much further ado, Dr. Drezner, welcome on the show. Welcome to Parallax, and thank you so much for doing this for us.
Yeah, absolutely. It's a real privilege to have this opportunity to talk with you.
Oh, likewise. The honor is ours. So, Dr. Drezner, if you want to walk us through the evolution of sports cardiology and sort of the culmination or the fruition of what I now deem as a bona fide subspecialty within cardiovascular medicine, and that is sports cardiology. How did this come up and come about? What particularly led to the evolution of the subspecialty within? I believe that it has been an integral component of family medicine for many years in comparison with, its path in cardiology.
It's a really good question. And I'll give you my perspective on it because I think my perspective might be slightly different than one, let's say, of a cardiologist, who finished their own training in that specialty. So, my training initially was in family medicine, and then I did a sports medicine fellowship. Fell in love with sort of the heart of the athlete, and my primary passion through my academic career has been the prevention of sudden cardiac death in athletes. And I think the field of sports cardiology really emerged from the tragedies in athletes that we would see in public view, cases like Hank Gathers, Len Bias, Reggie Lewis, that date back, 25 years ago. Those really came to everyone's attention, and it probably put sports cardiology, or really the beginning of sports cardiology, on the map, asking, why are the seemingly most healthy individuals in our society, those who can exercise and do amazing things, why are they collapsing with cardiac arrest, and why are they dying, after their collapse? And it raised a lot of questions. What's different? What's causing these cases? How frequent does this occur? How can we prevent it? Should we be doing better screening? Can we be more prepared to respond? And I think the field has just grown from those initial questions. What started with a really poor understanding of risk. When I was in medical school, which was really in the 1990s, I was told that sudden cardiac death in athletes was rare and occurred in maybe 1 in 250,000, athletes per year. Fast forward now, and we know that there are some athlete groups, so specifically NCAA Division I male Black basketball players who have an annual risk of sudden cardiac arrest of 1 in 2,000. And so that's really different in terms of how that should compel what we want to do from a prevention standpoint. Every loss of life is, of course, tragic, especially in a young person. But once it becomes more common, I think there's really, it warrants more of our attention and resources. So the early cases of sudden cardiac death and high profile they used search in newspapers and sources that they had to understand the incidence, and they were really underestimates. So fast forward with better mechanisms for case ascertainment, the revolution of sort of electronic day and social media and traditional media that we can search online and all that, you find a lot more cases. So we know that um, we have a better understanding of risk, still not a perfect understanding of risk. The etiologies, of course, in the young athlete are a diverse group of genetic, structural, electrical disorders, some acquired disorders that can cause, sudden cardiac arrest in athletes. And then, of course, the ongoing debate of screening. How do you screen? Should you just use a history questionnaire, basically, that, in my opinion, just does not have evidence that is effective? Or should you do something more like an electrocardiogram that clearly is a more sensitive tool, but requires expertise and an infrastructure to do it well? And then no one argues with the emergency preparedness piece that we need to be able to recognize cardiac arrest, people trained in bystander CPR, and have AEDs, available, on the field of play. And so the field of sports cardiology, I think, is taking on those issues, and it comes from different angles. So for me, I'm a team physician. I'm a sports medicine physician. I am charged with making sure my athletes are safe. I'm charged with doing a sports physical and providing medical clearance. I don't want to do that poorly. I don't want to just use a history and physical. I advocate for an ECG and something better. Um, and then, of course, responsible with my athletic trainer and athletic training sort of partners to make sure that we're prepared in case of an athlete collapses, in front of us on the field of play or on the court. On the other side, we have our partners in cardiology who've done an amazing job learning and growing the field of sports cardiology. So, from within the ACC, having their Sports and Exercise Council that has just grown in number and interest and in leadership, and people beginning training grounds like we have now at MGH and at Emory, and the real leaders in that space that have done great research and also provided terrific guidance in clinical care for athletes with diagnosed cardiac conditions and understanding how we should best manage them. And so I think the field of sports cardiology truly is multidisciplinary, because you can come at it from different angles. Obviously, what team physicians will be doing, has will stop at some point, and we need the help and management and care of our cardiology colleagues. But that's true in almost every patient-related disease that we know, where you have a team of healthcare professionals that provide the best care.
Yes, I have so many questions that have popped up. Excellent explanation of how this evolved and where we are now. Um, you mentioned there is a sentence you mentioned there, which I think encapsulated the essence of sports cardiology, and that is genetic disorders. You have structural disorders and you have electrical disorders. And so, I mean, some of the disorders which come to mind, as soon as a cardiologist listens to those terms in that fashion, are hypertrophic cardiomyopathy, which is the leading cause of death in athletes in the United States. You have catecholaminergic polymorphic ventricular tachycardia. You have Marfan syndrome. Um, so, I mean, as a director of a program at an academic health center at an organization which I'm sure has partnered with, state organizations conducting sports in the state of Washington. How do you? There are three steps in this, right? One, as you mentioned, is the epidemiology. So garnering an assessment of what the burden is. Then the second aspect of this is screening. How do we screen high school kids who want to pursue athletics? And then the third part is, well, what do we do once we've determined that this particular individual is at a heightened risk for sudden cardiac arrest on the field? Can you walk us through those three aspects of executing a program like yours?
Sure, I'll try my best. So the starting with the epidemiology, which to me is um, a key area in sports cardiology research is to understand, what is the risk and the burden of cardiac arrest in young athletes, and what are the causes, what are those etiologies. Um, the risk of sudden cardiac arrest in athletes, overall, if you look at numbers, let's say from the NCA, the annual risk is about 1 in 40,000 per year. But we know that some groups are higher risk than others. So males are about 4 times higher risk than female athletes, for reasons that we don't understand. Black athletes are higher risk than white athletes, and some sports make up the predominant frequency of sudden cardiac arrest. So two sports alone in the U.S., football and basketball, represent over half of our cases. And if you add soccer, you've got about 2/3, and if you add track and field, you've got about 3/4. And it's not clear if this is sport specific risk or honestly just some heavy reporting bias that we are searching media reports for most of these cases. And maybe there's some bias towards the more high profile sports, and that's what we're ascertaining, which raises lots of concerns about what we're missing in, across, different sports disciplines. Um, our numbers and our estimates in some groups, like I mentioned, male, adolescent, and young adult basketball is by far our highest risk group, really regardless of race and ethnicity. Um, and then looking at the other side of epidemiology, which is the causes and the etiology of these cases, hypertrophic cardiomyopathy is the most identified cause of cardiac arrest and death in our young athletes, probably about 20% of all of the cases. There are other cardiomyopathies that exist there: arrhythmogenic cardiomyopathy, dilated cardiomyopathy, non-ischemic LV scar. There are the electrical disorders, some of which are genetic, the ion channel disorders. You mentioned CPVT, long QT syndrome. I think people forget that pre-excitation in Wolff-Parkinson White is a known cause of sudden death in athletes. Probably about 3% of our cases. We have some just structural congenital conditions that are at elevated risk for cardiac arrest, specifically anomalous coronary arteries. I like to point out anomalous coronary arteries because this is an entity that is not found by an electrocardiogram. And so I advocate for ECG screening, but it's actually one of the more common causes of sudden death in young athletes that's not found by using an ECG. And what we have learned about anomalous coronaries, it is the leading cause of sudden cardiac arrest and death in our young adolescent athletes. So our 12 to 14-year-olds, our middle school athletes, and also common in our adolescent high school athletes. And so I always say in when I'm talking about screening, that if you have an athlete that presents with exertional chest pain that's concerning, or exertional syncope, that's an entity that has to be ruled out with cardiac imaging and not just an electrocardiogram. And then to finish sort of the etiologies, we have some of the acquired etiologies, specifically myocarditis, commotio cordis, blunt trauma to the chest, perhaps premature atherosclerotic coronary disease that we start to see in athletes, in their late 20s, early 30s. And then as you have the masters athlete 35 and older, the dominant cause very clearly is atherosclerotic coronary disease. And so, and you also mentioned aortas that they're another potential genetic condition, either affiliated with connective tissue disease or not. And so the variety of etiologies that can all lead to cardiac arrest or sudden death in athletes also makes it more difficult to screen. You're not screening for a single entity. There's no one tool that will identify all of them. Most of these individuals harbor these conditions and don't have symptoms. So maybe up to 80% of athletes who go on to have a cardiac arrest have no warning symptoms of their underlying disease, which makes it really difficult to screen with a questionnaire that's asking all about symptoms, because already we're missing the majority of kids at risk. Um, Identifying those who do have concerning symptoms is quite important, but using a questionnaire to screen like that just hasn't provided the sensitivity that we're really looking for. Um, and so the epidemiology of sudden cardiac arrest, which is really the driver and the foundation of why we need to screen, why we need to screen better, why we need to be prepared, um, is also complex, which makes the solutions in the next sort of phases. How do we screen? How do we be prepared? How do we manage these athletes? Also more challenging.
Yes. I mean, you would want the sensitivity to be really high of a tool that you want to use for screening these individuals. Um, and I'm asking. I mean, I know there is a debate on EKG. I know EKG is going to pick certain, but not all. Um, disorders. You enumerated quite a few, which are associated with sudden cardiac arrest. I wanted to ask if we could add. I mean, between getting a resting EKG 12 lead and a quick spin in the scanner, a CT is going to cover the vast majority of these disorders, don't you think?
Yeah, I haven't seen any studies using CT as a screening tool rather than a diagnostic tool. There's been some studies using echo, of course, or even MRI. For in the young kids, would the radiation from a CT be a obstacle? Um, I think no matter how we screen, whether that stops at an EKG or does include some sort of advanced imaging, where makes the resources and the infrastructure even more complicated to figure out on a broad basis. But no matter how we screen, we will not have absolute protection from sudden cardiac arrest. We will not identify all persons who have conditions at risk. In the studies on sudden cardiac death that our group has done, up to 20% are autopsy negative sudden unexplained death, which some may represent the genetic disorders and they haven't had the testing for like a channelopathy. But even still, we have survivors that have, unexplained sudden cardiac arrest, or what used to be called, I think, idiopathic, VF. And again, you've done massive workup and you still haven't found exactly, why they had their event. And so really, no matter how we screen, it will never provide absolute protection, for cardiac arrest during sports and exercise. Um, I'm really a believer of the screening objective, meaning we want to identify individuals with an elevated risk so we can intervene in an individual and disease specific fashion and really walk through a shared decision making process with that individual, their family, the physicians involved, and make a decision about sports participation that is right for them. But you can't do that unless you have the information, unless you identify. And the issue around ECG for a long time was, oh, we don't need it, meaning the incidence is so low, we don't have to do it. So when the Italians published their study, Domenico Corrado is the lead author in 2006 JAMA paper, a 25-year experience in the Veneto region of Italy, showing an 89% reduction in sudden cardiac death in athletes over 25 years with the addition of ECG in their screening process. Leaders in the US in cardiology and American Heart Association said, if our incidence is already as low, 1 to 250,000 or 1 to 200,000, as the incidence in Italy after initiation of the screening program, why do we need to do anything different? So that was that was the early 2000s, which was almost like just look the other way and accept your numbers, which ultimately were not accurate. And now that we know we have more information, the screening debate sort of changed. So it wasn't about incidence. It was more about, well, false positive rate. We don't know how to look at an ECG. And thankfully, there's been several iterations of ECG interpretation criteria that a sports medicine physician or a cardiologist can and should follow if they're using ECG as a screening tool. and it has dramatically lowered the false positive rate. So false positive rates that might have been 20 or 25%, a couple of decades ago, where, you didn't clearly recognize physiologic adaptations in the athlete's heart that show up on the ECG. You didn't recognize those as a normal expected physiologic, finding. That would just raise the false positive rate. So putting those all in sort of one box, what we call the green box, of our criteria, that those are normal and accepted, you're really just looking at the findings that truly distinguish, in anyone, athletes and non-athletes, the presence of underlying condition at risk for SCA, like that we're looking for in the young athlete, the cardiomyopathies, the electrical disease, et cetera. And so that false positive rate, in my practice, in our high school population, our false positive rate is probably 1%, possibly less. In our college athlete population, under 2%. And so we know we can do this well, but we've also gained experience and trained for it. So the issue with more broad based ECG screening truly is expertise and infrastructure, meaning sports cardiology, as we started off talking about, is sort of a new field. And we just don't have infrastructure throughout the US that can provide a high quality ECG screen with regularity, and also have the cardiology resources around them to do the downstream testing. So when you have a ECG abnormality, what's next and what you should do, that should also be done by experts who know what they're doing. And so you have to have all that in place before you start your screening program. But it's not rocket science. There's a lot of models and there's a lot of people doing it, and it clearly is growing and becoming more common. And we've made a huge effort in terms of educating and training physicians on ECG interpretation so they can start with that, to me, the sort of fundamental tool of cardiovascular screening in athletes, and do it well and feel confident in it.
Yeah, so I think what will be helpful for our listenership would be to hear from someone like yourself who directs a program at a major academic health center, to just walk us through what happens when a patient who's come in to see you for a screen, a high school athlete or even a younger athlete has come to you for screening for suspected causes that we've enumerated and discussed briefly, which may lead to sudden cardiac arrest on the field. Walk us through, some of the questions that you ask, some of the aspects on the physical exam that you focus on, and then certainly investigations and how you go about it. Maybe genetic testing, may not be genetic testing.
Our Center for Sports Cardiology at the University of Washington emerged from a really strong collaboration between sports medicine and cardiology. And so I'm thankful for all of my friends and colleagues in cardiology around me who really enable the sports medicine team to do some of the initial steps in our program. But we offer advanced heart screens to youth and high school and college level individuals, starting at age 12. And so at age 12, if they want an ECG heart screen, they can call and schedule a heart screen with me or any number of providers. When they come in, they get a very heart-focused visit, which is a brief questionnaire of cardiovascular-related symptoms and family history, a focused cardiovascular exam, and a 12-lead ECG. And most of the time, all of that is normal, and they're on their way. And we suggest, that they have an evaluation like that, every 2 years while they're still active in sports. That evaluation is a little bit different if someone is presenting with symptoms, where obviously it's more just like a typical office visit where they're calling in because of concerns, chest pain or syncope or something like that occurred with exercise, or perhaps a family history. The visit might take a little bit longer. We dive a little bit more, and there might be more diagnostic testing. If the ECG is abnormal, then they're going to need more evaluation, and it sort of depends on what the finding is, would guide the extent of that evaluation. But let's say that for most of them, it would involve at least an echocardiogram, sometimes cardiology referral, sometimes warrant a cardiac MRI, depending on, or a referral to an electrophysiologist, depending on the finding. Once you have a condition at risk identified, I think it's really important that they have a consultation by a cardiology specialist within that space. And so we're lucky at the University of Washington, that we have experts in cardiomyopathy, we have expert electrophysiologists, experts in congenital heart disease. And we also partner with Seattle Children's Hospital for our younger age group, for things like anomalous coronaries and whatnot. And so getting those in the right hands, and I would say often continuing that collaboration. So if it's my patient, I'm still part of the discussion, really from the sports and the sports medicine perspective. Sometimes translating for the patient and the family what's happening and what the risk is and what should they be thinking about, and of course relying and leaning on our cardiology specialists to give them advice and recommendations on how best to manage it. Many of the conditions that once were sort of a binary yes no eligibility question, you're either diagnosed with a condition or you're not, and if you have a condition at risk, then sports is over, has really moved to a shared decision making model where it's very individual, disease specific, and context specific in terms of coming up with what that plan is. And so not everyone is obviously disqualified or ineligible from sports, and that creates now its own new space. We are studying this with something called the ORCA study. It's the Outcomes Registry for Cardiac Conditions in Athletes, and we are enrolling young competitive athletes who are diagnosed with a heart condition at risk and following them over time for cardiovascular outcomes, quality of life, mental health, physical activity levels, and we have sports cardiology centers around really North America and now Australia enrolling, and very excited about what that data will show over time, as we get more cases that we can follow. But I would say from a programmatic standpoint, you have to offer the screen. Insurance doesn't always cover it. At our institution, if you're paying out of pocket, you pay $50 for the whole screen, which is different than an office visit for symptoms. And then, of course, you've got the downstream workup if you need it, and management of the disorders if they come up. So it walks that full process.
Excellent. I'm going to ask you the three most common conditions that you encounter in your practice, which lead to downstream testing and further recommendations for patients. And then I'm going to go to the other spectrum and ask you the three zebras that you've encountered.
The three most common conditions that come up, number one, pre-excitation WPW. We find in our heart screens at our local high schools, about 1 in 250, maybe 1 in 300 kids has that specific, finding on an electrocardiogram. And it used to be that you would exercise test them and see if you have cessation of pre-excitation and the delta wave goes away and all that at faster heart rates as a mechanism for risk stratification, but that didn't really pan out. So really everyone who's a young competitive athlete, in my opinion, needs to see an electrophysiologist and at least consider ablation. Hypertrophic cardiomyopathy, its prevalence in the adult population about 1 in 500. In competitive athletes, it might be about 1 in 2,000, but still certainly there. And hallmark features on an electrocardiogram would be infralateral T-wave inversion and ST segment depression that really warrant not just an echocardiogram, but often a cardiac MRI to look more closely. And our understanding now within that space of apical HCM, which is one of the more common phenotypes in athletes that harbor HCM, where the diagnostic criteria is just a little bit different. The walls may not be as thick, and the apex just doesn't taper, and it looks as a relative thickness to it. And then The third most common sort of condition, we're obviously evaluating athletes for long QT syndrome. And sometimes a single ECG, of course, is not enough to make that diagnosis. Sometimes it's misread. Sometimes their heart rate is too slow or too fast to really have an accurate, QTC calculation. Perhaps they're on medication that's involved. And so not over-diagnosing that condition, I think, is really important. And repeating some steps to know whether or not they have that channelopathy. Repeating their ECG, perhaps family screening, could be genetic testing, a stress test, and looking at their QT and recovery, etc. The flip side, the three zebras, what we're sometimes seeing, there is a new kid on the block, a new entity that we have seen, but it's been characterized by colleagues of ours in Italy, and it's called non-ischemic left ventricular scar, and essentially looks like mid-myocardial big circumferential stripe of LGE, late gadolinium enhancement. It's not subendocardial, like ischemia or something, and it's not necessarily myocarditis, and it's not patchy and with other findings of other types of cardiomyopathy. It sits somewhere in a dilated or a rhythmic or its own entity space within the cardiomyopathy spectrum. But I think it's newly characterized. And what we've noticed is in these athletes, they have an abnormal ECG. They often have a normal echo, sometimes maybe a borderline low ejection fraction, but nothing that really stands out. And it's really the cardiac MRI that's essential to make the diagnosis. And I find that this is really one of the more arrhythmogenic entities, which makes me more concerned. So that's to me, sort of one of the new kids on the block. Another area that I think is comes up, maybe not a zebra, but with enough frequency to understand how to differentiate it, are finding borderline ejection fractions in athletes, and what do you do? And so that athletes can have bigger chambers and slower heart rates, and maybe they don't need the same ejection fraction at rest. And so, before saying someone has a truly abnormal ejection fraction and a big chamber, which makes you more concerned of like dilated cardiomyopathy, sorting that out from just athletic, exercise-induced cardiac remodeling. So, getting an MRI, ruling out other findings in LGE and SCAR, getting a stress echo and looking at that LV reserve is really important. And just sort of differentiating, I think, the people who truly have sort of the early stages of a dilated cardiomyopathy, but early enough that they're quite functional and can play sports, versus those who just have the extreme of athletic remodeling and sort of a low normal ejection fraction. I think that's definitely a challenge. And if you're asking about one other sort of zebra that comes up, and again, I'm not sure it's a zebra, but more of a challenge, is just differentiating hypertrabeculation, which is more common in athletes and more common in younger individuals, from true left ventricular non-compaction cardiomyopathy. And those are challenges. And again, not every time you see hypertrabeculation does a person have LVNC, and we get that referral a lot from the community in athletes who maybe got an echo for different reasons, or had a subtle finding on their ECG, or maybe had a murmur, and then suddenly they're being told they have LVNC, and they really don't. And it's just a normal variant and not really representative of a cardiomyopathy.
Excellent. In terms of executing, resources and sort of mobilizing resources on the field, should an athlete have an event like this, an unfortunate event like this, maybe if you can describe for the listenership the preparation that goes from a sports cardiology perspective when you're accompanying them to games, I think that would be helpful.
Yeah, yeah. So this is universal and not just because you have an athlete on the team with a known condition, right? So we have to have proper emergency preparedness for cardiac arrest at all of our sporting facilities and sporting events. This is a top priority for sports medicine and athletic training. Um, so what does that entail? It entails that you have an emergency action plan. That this isn't the first time that you've thought about it. An EAP usually has an EAP coordinator, someone at the school or facility that's responsible for it, making sure the AEDs are there in working order, et cetera, making sure that staff are aware where they are and that the proper people like coaches are trained in CPR. Um, when you have a sudden collapse during exercise and the individual is collapsed and unresponsive, in the sports medicine community, that is cardiac arrest until proven otherwise. There are some features or signs of sudden cardiac arrest in an athlete that often can confuse a rescuer. And I think we're part of initial delays in resuscitation and lower survival rates from a couple decades ago compared to now. And some of those signs and features, when an athlete collapses during exercise, they almost universally have their eyes open with a fixed gaze or eyes rolled back. 30 to 50% have some brief seizure like activity for maybe up to 10 or 20 seconds. And almost all of them have some continued chest movement where you see some continued sort of respiratory drive coming from the brainstem that may last 10, 20 seconds before it deteriorates more to like agonal, respirations and breathing. But if you get there quick enough, all of those things can make you think it's something else. The person's awake, they're still breathing, they're having a seizure. I've heard unfortunate tragedies where they appropriately called 911 and they said, little Johnny's having a seizure and an AED is 100 feet away and they never got it. And dispatch didn't sort of reroute them to say, start chest compressions. And so I think people have to be aware of what those like signs are and recognizing SCA. And in the sports medicine community, we made this simple. If they're collapsed and unresponsive, and that's unresponsive to a shoulder tap and verbal stimuli, this is cardiac arrest until proven otherwise. So we're going to call 911, start chest compressions, and someone's going to go retrieve the AED. This is counter to what the CPR guidelines say, which really suggests the fork in the road is diagnosing, normal versus abnormal breathing. And I would argue that no layperson can do that. Certainly not in this setting with an athlete who's collapsed. And most medical providers can't do that, certainly in this setting, because continued respiratory movements are so frequent. And so that really needs to go away. And I had a chance to collaborate with the Resuscitation Council UK. So in the UK now, they have these actually embedded now in their guidelines and their CPR guidelines. There's sort of unique features of SCA in exercising individuals and young athletes. The rescuer should understand CPR, specifically chest compressions and how to do it well. And then the most important thing is that we need access to an AED. And thankfully, AEDs have become more common, but we still need more of them. So at schools, they're present usually indoors, but sometimes not outdoors. And our public playfields in the community where our kids recreate, where people go jogging, there's often not AEDs at those outdoor fields and baseball diamonds and multi-fields, complexes with soccer, tournaments going on and things like that. And so there's a level of emergency preparedness that we can improve on by having more access to AEDs. But it really is that combination. The sooner you recognize it, the sooner you start chest compressions, the sooner you get the AED applied for that first shock, the better the survival.
Yes. Well, thank you for those insights into the execution of what transpires on the field. For someone who's listening who is interested in developing or establishing a sports cardiology program in their organizations, where should they start? What would you recommend in terms of, a checklist of items that they should check off the box right away to get started?
Well, I mean, the first thing is making sure that you have the expertise either yourself or around you, to support a sports cardiology program. I think the foundation is ECG interpretation in the young and ECG interpretation in athletes, making sure you do that well, making sure you have a cardiology team around you that can, accurately interpret an echo in a young person and a young athlete. Same thing with cardiac MRI. I think those are critical features, and it's something that I think University of Washington does really well with my colleagues, that I feel very confident when they're looking at it. And I don't know if every location has that, that possibility, but I think making sure you have the expertise and the team around you is probably a core to beginning a sports cardiology program. Then it's about, how do you want to promote this, advertise it, get the word out, et cetera. And for that, I think you have to be active in your community, and you have to have some community partners that might help you with this. So that might be partnering with some local foundations that are doing screening, perhaps so you gain experience, or perhaps for referrals, making yourself active in the local sports community, and making sure people are aware that they can get an advanced heart screen if they want to, going and talking to those programs and teams and helping them with their emergency plan, and then talking about screening. And so I think that's part of it. For our sports cardiology program, the biggest area of growth for us has actually not been in the young athlete, but more the master's athlete, the aging athlete. And I think there's a huge space in any community that, to me, is still sports cardiology, or really sports and preventive cardiology, which is just expanding these principles of screening and prevention and early detection to the adult athlete. And how do you do that? So for us, we're using coronary artery calcium scores, and a battery of labs, and a good discussion and evaluation to walk through that. But a lot of adults who are exercising a lot want to make sure they're as safe as they can be. And what do they do? And again, it's about some of that early detection of what might be there, and then individualized management.
Yeah, no, excellent. Any closing remarks? Anything you think we may have missed or not touched upon for the show that you would want to share with the listeners?
No, I think, like you brought up in the beginning, I think sports cardiology is a really exciting field. I think it's growing. I think there's so much more to do. So if you're interested in getting involved, please do. And I think there's lots of ways you can do it.
Yeah, excellent. Well, Dr. Drezner, this was a tour de force. Thank you so much for walking us through the nuts and bolts of establishing a sports cardiology program, and some of the common conditions you encounter when you screen, athletes, early on in their careers, or, established athletes. For those of you who are listening, if you have any questions for Dr. Drezner, feel free to email them to us, and we'll make sure that we forward those questions to him. As always, do drop in a feedback. You can rate us, review us on social media platforms, or on the podcast platforms that you use to download Parallax. And until other Monday, thanks for listening.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.